Cardiovascular emergencies. One of the biggest improvements in pre-hospital medicine is cardiac care and the recognition of cardiac emergencies. Up until the mid-70s, you still had ambulance services with relatively untrained people. Often they were, as they moved away from the funeral home based ambulances, they had fire department based ambulances that maybe had 2 people trained in first aid, or 1 person trained in first aid. And then as the 70s wore on, you started having maybe 1 EMT on the truck, and then that evolved to eventually adding a paramedic on the ambulance. For instance, in Amarillo, the first paramedics hit the streets in 79, I think. So that sounds like an eternity ago to you. That was 3 years before I started working in Amarillo. So I don't know, I'm an old man. Just look at my bald head and all that other stuff. But that's what changed over that time. Is doctors over time evolved to the point that they saw the need to put people on the streets who could not only deal with trauma, because early on that was the focus. We had to educate people on trauma. Then it was, we need to take CPR that we're doing in the hospitals and get that moved to the streets. And then we needed to do something maybe to provide earlier recognition and earlier treatment of heart attacks. And as time has passed and equipment has improved, more and more has been put on EMS as far as the recognition and treatment of cardiovascular emergencies. But before you can run, you have to learn how to walk. So today we're going to start taking our first steps in cardiology, building toward that time when hopefully several of you will go on to paramedic school, and you'll be doing things like interpreting diagnostic EKGs. By diagnostic, I mean what we call a 12-lead EKG. It takes different electrical images of the heart, and through that you can focus in on exactly which coronary artery is occluded in a patient, notify the hospital so they can have that vehicle we call the cardiac cath lab fired up and idling, so they're ready for your patient when you get there. And you're gonna, I may say this several times today, or I may forget to say it at all, but time is muscle. When a patient has a heart attack, circulation is lost in 1 or more of the coronary arteries. So part of the heart muscle is starving for oxygen and glucose. And after a short period of time, heart cells begin to die, and you can't get those back after they die. They don't regenerate. They're lost forever. So what you do as EMTs, and with the addition of some pharmacologic agents that you could employ as EMTs, we are decreasing that heart muscle loss. And door to balloon time is what they talk about in the hospital. Balloon time would be when the cardiologist does the heart cath, actually goes into the patient's body and makes it up to the heart with the catheter, injects dye, sees where a blockage is. Balloon is when they get ready to put a stent in. They spread apart, they grind away plaque inside that coronary artery that's causing that occlusion, and then they pop a a little metal mesh stent in there to hold that open and restore circulation. So that's what, if you hear them talk about door to balloon time, that's the goal. If we call a heart attack alert or a STEMI alert, which is a type of EKG that is indicative of a heart attack, then they're up and running, they're ready to go. We hit the door and they draw some labs, maybe shoot some couple of chest x-rays, and then straight to that cath lab the patient goes. And it's amazing the short period of time that is involved there and the muscle that's saved. People who leave the hospital 2 days after being in the process of having a major heart attack, rather than dying or being in the hospital for 2 weeks and then returning to a debilitated life. So let's start laying your foundation. Things that we can do in EMS to reduce deaths. I doubt I'm going to give you an exam question so that you just have to lay these out, but let's talk through them really quickly. Encouraging healthy lifestyles. In EMS, we probably live anything but healthy lifestyles. We eat on the run. We work lots of hours, which takes away time to exercise. We leave work exhausted. Last thing we want to do is exercise. Have crappy diets, and so kind of we hit that point of do as I say, not as I do. So it takes a conscious effort on your part to maintain that healthy lifestyle, and you really need to focus on that and work on that. I am not a good specimen of that one. Early access to medical care. What have we done there? Years ago, you had to know the number to call to access an emergency ambulance, or you had to dial 0 and the operator had to patch you through, and all of these steps. And in the late 80s, like 88, 89, around in there, we finally got 911 in Amarillo, enhanced 911, so it pinpointed what address the person was calling from with a landline. Cell phones have made that a little more complicated, but there have been some advances there also. CPR training for lay people. We do a lot of that. That would include teaching people about AEDs, how to find them in public locations and in offices where they work. And I think a place we fall short is convincing people not only to learn CPR and learn to use an AED, but to actually employ it. People are scared to death to use what they learn. They're afraid they'll forget. Oh man, is it 30 compressions and 2 breaths, or is it 15 and 2? Man, something's better than nothing. And CPR changes every 4 or 5 years. So it's just getting people to get past that fear of not knowing exactly what they're doing. And then ever evolving technology and dispatch and response. We get more information through computer terminals in ambulances than we ever got before, if it's input correctly. So I think training dispatchers, that's still an ongoing need. That is an extremely high stress job, lots of turnover, and you lose experience every time somebody goes out the door. So learning how to get information, how to input that, and getting information from the public. Yeah, people freak out, understandably so, but it's the old computer acronym, GIGO, GIGO, garbage in, garbage out. If you don't get good information, if the dispatcher doesn't elicit good information from the caller, they can't give us good information on the way. And then I already mentioned this, but I think it's important enough that it goes up there with CPR, but access to AEDs, and again, getting people to use those. afraid they're going to hurt somebody. You can't make dead worse. So I mean, you can if you don't do anything. If they're clinically dead right now, meaning they don't have a pulse and respirations, and you don't do anything, you do make that kind of dead worse, because then it becomes actual death or legal death, or they're not coming back from that. And then specialized cardiac centers, that goes with that door to balloon time I was talking about, having chest pain cardiac hospitals that we transport to. We might in a large city, we might bypass 2 other normal old emergency departments to transport 3 or 4 or 5 more minutes to get to that cardiac hospital, so that that door to balloon time is as short as possible, so we save as much muscle as possible and get people back on the street. Let's talk about briefly, a little bit more than briefly, we're going to talk about some of the anatomy and physiology of the heart. That's important. You have to know, I think, to know how to effectively treat a patient with acute coronary syndrome, and that would encompass angina, the traditional squeezing chest pain, up to having full-blown myocardial infarction, the big MI, where the patient is experiencing death of heart tissue. That is all encompassed in ACS, or acute coronary syndrome. We need a foundation of some anatomy and anatomy of the coronary arteries, and that will help you better understand, I think, what's going on with your chest pain patients. So we're going to divide that into overall cardiac anatomy. That's just how the heart works. And I've tried to hit that multiple times as it comes up in chapters, talking about central circulation, and talking about so we know that deoxygenated blood comes into the right atrium. Then it goes through tricuspid valve into the right ventricle. Right ventricle. I always draw all this on the board, so if I stumble some through here, it's because I'm trying to picture it in my head and make sure I don't skip stuff. So it goes right atrium through tricuspid valve to the right ventricle. The heart contracts, the ventricles squeeze from the bottom up, because the valves that where blood exits from the ventricles is up at the division between the atria and the ventricles, so that it squeezes blood upward. And on the right side of the heart, it goes out through the pulmonic valve into the pulmonary arteries. Pulmonary arteries lead to the lungs. That deoxygenated blood circulates out into those capillary beds, where hopefully we have good gas exchange, which is what? Alveolar respiration, right? We keep talking about it over and over. Why? Because it's important. You're tired of hearing me say that, right? Why? Because it's important. I'll say it again. Oxygenation takes place, and then that oxygenated blood returns to the left side of the heart via the pulmonary veins. Veins lead toward the heart, arteries lead away. So the pulmonary veins are the only veins in the body that carry oxygenated blood. That goes back to the left atrium, and then through the mitral valve, which is a bicuspid valve. It has to be stronger. These valves are thin. They're fibrous tissue, tougher than ligament, about as tough as ligaments, about the same material probably as ligaments. Those of you who may already have more anatomy classes under your belt, and obviously much more recently than mine, will remember that. On campus, some semesters I'm able to secure either a pig heart or a cow heart, and I can cut that open and show you that fibrous material, show you all these arteries and stuff, and I can't do that right now. So we're just going to describe it. That blood goes through that bicuspid valve into the left ventricle. The left side of the heart has oxygenated blood. The left ventricle squeezes from the bottom up. The aortic valve opens. When you hear the lub dubs, when you're auscultating heart tones, the lub dubs that you hear are valves opening and closing. So you have the aortic valve opens during ventricular systole, and that ejects the blood from the left ventricle out into the aorta, follows the aortic arch around, coming off the aortic arch. You have the subclavian arteries, you have the carotid arteries, and so coming right off the aortic arch is the circulation of oxygenated blood to the upper body, and then leaving the aortic arch, we move down the descending aorta. That's carrying oxygenated blood down to the lower body. That splits off into the right femoral artery, left femoral artery, then the iliac arteries, and then it continues splitting, going on down. Subclavian arteries up at the top, those divide into the axillary arteries, then the brachial artery, and I guess just not the axillary artery, it divides into the brachial arteries. Those divide into the radial artery, which is the location when we palpate a pulse on a patient's wrist, we are on the thumb side, we're palpating the radial artery. Over on the pinky finger side, that is the ulnar artery. In some people, if you feel long enough and you move around a little bit, you can find that ulnar pulse, but it isn't as superficial and it's not as easy to palpate as the radial artery. So that's the division. It just branches out like trees from that aorta, the largest artery in the body, down to eventually those capillary beds. Capillary beds, think of them as one red blood cell in circumference. There's room for that one red blood cell to come through. So what can happen so that respiration can happen, exchanging those gases, that delivering oxygen and nutrients, including glucose, to the tissue, carrying away carbon dioxide. Same thing I've talked about until you're tired of hearing me say that. So central circulation would be the aorta, and then the aorta continuing down the abdominal aorta. Central circulation perfuses organs. So you have the renal arteries coming off to perfuse the kidneys. You have major circulation to these organs, and that central circulation. Now let's talk about peripheral circulation. That is all those branches that come off of the aorta going to starting with the subclavian arteries, the carotids, those perfuse the brain. That's part of central circulation. Central circulation, when a patient goes into shock, or even after a patient dies, the arteries in central circulation remain patent. They don't vasoconstrict down. They remain open. They're relatively easy to cannulate, to start an IV. It is a much more involved process. Some of those central lines, the subclavian artery, Those are within the scope of practice for paramedics in certain locations. They used to be done in the street here back when I worked in the street, and now we just drill bones instead. Much faster, less complications. So have central circulation, peripheral circulation, that would be your extremities, right? Now, so there's two types of circulation. We need to add a third because the heart muscle itself, it needs to have circulation. So let's talk about coronary arteries. Remember back classes number 2 and 3 when we did CPR. Seems like an eternity ago, which it was a month ago, but it seems like an eternity ago. And we emphasized in chest compressions, allowing for full recoil with every compression. And we said things like get off the chest, get off the chest. We wanted that full recoil. Why do we need that full recoil? Full diastole is when blood enters coronary circulation. Right behind the aortic valve, it are structures called coronary ostia, and that's not even in your book. Coronary ostia isn't in your book, but I want to start getting that in your head for later in your career. I think your book may just say there are openings that allow blood to enter coronary circulation, feeding the heart muscle itself. During systole, when the aortic valve is open, that covers the coronary ostia as that blood's ejected, oxygenated blood is ejected and circulates through the aortic arch. As it relaxes, and you can picture, if you've ever watched a ship go through a lock and they open those two big gates to allow water to move, and then they close the two big gates. Think of those two big gates as being the aortic valve. And when those are open, that covers the coronary ostia. And then as those two gates, like the ship lock, close, in full, when the ventricles are at full arrest, those coronary ostia are open, and oxygenated blood, that last little bit of oxygenated blood coming out of coming from the left ventricle, that blood moves into the coronary arteries to provide blood to the heart muscle itself. I'll have some, now that we've talked through it, let's kind of look at it here. So comes into the right atrium. Blood moves through that tricuspid valve down to the right ventricle. This is all deoxygenated blood. Now the pulmonic valve opens. The aortic valve opens at the same time, but the pulmonic valve opens and the blood ejected from the right ventricles enters the main pulmonary artery. Then that branches out to left and right, and then those divide out into the lungs, just like we talked about. Now we have oxygenated blood that comes back to the left atrium, which is buried down in there somewhere behind that main pulmonary artery. Down in here, comes back through that pulmonary vein into the left atrium, through that mitral valve, which is that stronger two-flap valve, and moves into the left ventricle. The left ventricle is larger and thicker. The muscle is larger and thicker slightly than the right, because this left ventricle has to eject blood to perfuse everything from your from your left arm and your right kidney down to your pinky toe on your left foot. So all of that blood is ejected through the left ventricle out that mitral valve into sorry. It's ejected from the left atrium through the mitral valve into the left ventricle. Now it's pushed up from bottom to top, and now there's that aortic valve I'm talking about, and that oxygenated blood, stroke volume, the amount of blood ejected from the heart in one cardiac cycle, mainly talking about this left ventricle, the blood ejected from the left ventricle into the aorta, so that's measured in milliliters per systolic contraction, and then that sends the blood out. And then you see the subclavian artery exit there, and then your carotids there, and you have there's common carotid, and then there's internal and external carotids. That there's some redundancy there to make sure that the brain's perfused, because if the brain dies, you have to become a lawyer and then eventually become a EMS professor. So, all right, so that is that circulation. Now, this aortic valve is closed, so what is open and available to receive oxygenated blood? That last little portion that makes its way into the aorta. The coronary ostia are open. There's not a valve there. It's the opening and closing of the aortic valve covers and uncovers those ostia that allow blood into the coronary arteries. They look like this. Coronary arteries provide the perfusion or oxygenated blood and nutrients required by the heart. The heart doesn't store up oxygen and nutrients. It needs a constant supply. And as that blood comes out of comes through those ostia, you have one that heads to the right side of the heart, one headed to the left side of the heart. First, you have the left coronary artery and the right coronary artery. Then you have a division, and you have the left anterior descending and the circumflex. Those perfuse the left ventricle. What does the left ventricle do? It pumps oxygenated blood out to the rest of the body. So that is, if you've ever heard of a Widowmaker MI, that is a blockage in this left anterior descending. And I think I have maybe an animation to show that here in a minute, if it will work. And then the right coronary artery, that perfuses the right ventricle. This left anterior descending, that kind of roughly follows the ventricular septum, which is that fibrous material that divides the right side of the heart from the left side of the heart. So we can actually electrically look at, when we talk about an EKG, think of a camera. So you have a positive and negative pole, and electricity moves away from a negative pole toward a positive pole. So all those stickers that they put on somebody's chest, they're getting different views of electricity moving through the heart, where do I have that? I don't have that. I draw this on the board. Okay. Now you're just going to have to picture this. No, wait, I do have I'm going to back up when I okay. Now we're going to talk about the electric system. We've talked physically about what's happening with the heart as it contracts. We've talked about getting blood into the coronary arteries. Now, how does the heart know to contract? That's an important question, right? It is an important question. The normal electrical activity in the heart originates in the sinoatrial node, SA node. And then there's the atrioventricular node. Look where that sucker sits. It's right there where the roads come together, it looks like. You have the division between the top and bottom of the heart, and you have the division between the right and left side of the heart. That atrioventricular node sits right there at the two, so our electrical impulse originates here. It moves away from the SA node via the internodal pathways, and as that impulse travels along, and normally that is less than 0.2 seconds, that travels, that electrical wave moves along. It's not wires, but you can picture wires running through the heart that carries that current. As that moves along, that electrical impulse triggers these heart muscles to contract, just like any other nerve impulse does in the body. What do they do to generate work? They cause muscles to contract. So that wave moves along here, that causes the atria to squeeze down, right? That's what pushes blood to the bottom of the heart. Then that impulse hits the AV node, and it delays that impulse slightly. Why? Because we need the atria to fully empty into the ventricles. So we have that delay right there, and then that impulse eventually overcomes that resistor, because it acts as a resistor that slows down an electrical current. And that resistor, the AV node, then the electric impulse moves from there into what's called the bundle of His. That hasn't divided into right and left yet, has it? Nope, it's still just one impulse. Now we hit a division into bundle branches, the right bundle branch and the left bundle branch. What does that look like as that wave is moving along? It looks like we're starting to squeeze at the top, moving down toward actually the apex of the heart, but we're moving down to the pointy part of the heart. But something strange happens. That I told you that the heart contracts from the apex toward the atria to eject blood from these valves up here. So when the impulse hits these Purkinje fibers down here and these fascicles, you don't have to worry about those yet. I pulled this slide out of the paramedic book, but contraction starts down here and moves upward. So that is normal conduction, and that has its specific pattern. Well, this one doesn't have it. Anyway, we'll see an EKG in a minute, but that has a specific pattern in an EKG, and which I usually draw on the board at this point. You're tired of hearing me say that, but this is semi-frustrating for an old man. Okay, so, and these different, okay, see this chart down here. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. I talked about a 12 lead EKG. These are 12 different camera views of the heart. So if we take lead 2, which is down here in Roman numerals, lead 2 is our normal, on the regular old cardiac monitor, lead 2 is usually where they have it selected. So we get a view of electricity originating in the SA node and moving down to the ventricles and then allowing for ventricular contraction. Incidentally, it is possible to have a perfectly normal EKG tracing that isn't being captured by any of the myocardial cells, myocardial meaning heart muscle cells. You have a perfectly normal EKG and have no pulse and be clinically dead. So I don't know why I felt that important to throw in there, but lead 2, we get that normal view originating in the SA node down to the AV node, and then we get the big up and down in an EKG complex, the electrical part of one beat, EKG complex, that we get a view of everything making its way all the way down to the ventricles. And then when the ventricles repolarize or go back to a neutral state and get ready to be excited again, so that we have another heartbeat. That's important. One after another, after another, after another. As I've stumbled through this, since I can't draw it, it seems like those have been lots of heartbeats waiting for Buddy to catch up. That's all we're going to talk about this. Well, let's say our patient is having that Widowmaker MI. We have this left anterior descending coronary artery blocked. Where would we see that? Because I told you that as a paramedic, you can look at an EKG and tell exactly where in the heart that blockage is. LAD is represented by this V1 view and V2 view, like little cameras sitting there looking up, waiting to see electricity move toward them, and then V3 and V4 also are involved in looking at that left anterior descending. So we can, that's how we tell what's going on in the heart. That is fairly recent addition to the EMS world. I'm going to say somewhere between, with most services, between 12 and 20 years ago. That sounds like an eternity when you're 20 yourself. That's a whole lifetime, but in the lifespan of EMS, that isn't that long. Why did it take us that long to teach a paramedic how to do this? No, I learned how to do this back in the 80s. The problem was there weren't portable EKG machines that could do this. So takes a fragile instrument to do all this, and they hadn't developed a portable, durable EKG machine that we could use. But fortunately they have, and people are living because of it when they otherwise would have died. So this is an image from a heart cath. What do they do in a heart cath? They find your femoral artery or your radial artery, and they poke a hole in it and they send a catheter up it. What's a catheter? It's a hollow tube. They send a hollow tube, maybe a hollow tube that has 2 or 3 little tubes inside of it that connect to little stopcock valves so that you can do different things down on the doctor end of it. They run that tube up to the aortic arch, right above where I told you those coronary ostia are, and they inject dye, and that dye goes into coronary circulation. See how you have dark lines up here as that dye goes into these arteries, and then it gets really thin and faint there. There's your blockage. The machine called that 95%. That means there ain't much oxygenated blood making it past there. And if we put stress on the body so that the heart muscle has to work harder, that's when that chest pain comes in, because the heart hurts because it doesn't have enough oxygen. You ever run in PE and then you start getting like your side hurts, or you get muscles that hurt really bad? They're starved for oxygen. That's why you have the pain. That's what's happening with cardiac chest pain. So you have that narrowing, and we call it run the roto-rooter through. They go in and the plaque that's on inside of that artery, that all those lipids, all those good cheeseburgers and sausage, egg, and cheese biscuits, and all that red meat that like brisket that has lots of fat in it, all that lifetime of that, plus some genetics and maybe some other things like smoking, causes buildup of plaque on the inside of those coronary arteries, to the point now that not much blood's getting through. So that plaque in there, they actually run a tool up there that scrapes away that plaque and suctions out the pieces, so that we don't just break that blockage up and push it down to smaller vessels. Open that up, and occasionally they go through the wall, because it's not, that stuff is there. It's like cement that they're having to scrape away and suction out. And sometimes they poke a hole in a coronary artery, and that can be lethal. I have a good friend who died that way. They scrape away until they can get the balloon in there. Then they spread that balloon, they inflate that balloon, and it spreads the lumen, the inside diameter, spreads that open, and then this slinky looking thing, it's like a metal mesh that they slide in there, and it's collapsed when they put it in. Then it pops open and it spreads open that coronary artery. After stenting, all the way on your right now, there's a stent in there, and look how big that left anterior descending is now versus what we had over there. And look how much better it looks like we're perfusing downstream from that. So that is what a heart cath does. That's what we see with a heart cath. Hopefully we're able to place a stent. Prior to stents, what did they do? We had to call in a plumber, right? Anybody ever heard of bypass surgery?
Yeah, so that's what I was going to ask you. So what's the difference in a stent rather than taking vein from your leg?
Yeah, with stent is a closed procedure. We don't have to open the chest up to do that. But
Okay.
if this is in an area that can't be stented, then this person has to go to surgery, and a cardiothoracic surgeon has to open their chest up, and they can even do this on a beating heart now. But they take a piece of vein, and they cut a hole. They cut a hole up here in this artery, and they cut a hole down here in the artery, this coronary artery, below where the blockage is, and they sew that piece of vein in, and they plumb around that blockage or blockages. So what's the difference in a bypass and a triple bypass? A bypass would just be one. You have to plumb around one blockage. Triple bypass, quadruple bypass. Triple would be 3 coronary arteries that had to be replumbed, and a quadruple would be 4. So that is and double bypass is 2. So that's what a bypass is. And then so now that is open, and that little piece of vein allows circulation to go past that to hopefully do this, except for you're still going to see the blockage, but you're going to see that piece of vein in there if there was a subsequent heart cath. Interestingly enough, if this blockage comes on slowly enough and the patient is genetically wired to do this, the body can actually develop what's called collateral circulation, so that it does its own bypass. It doesn't provide as much perfusion and blood flow usually as the man-made one, but God built in a repair system there in some people. All right, that makes sense. Understand something now that you didn't know before? I love this stuff. I have to pick up speed. You can tell the stuff I really like because I kind of get hung up there sometimes. Now, if I can make it work, let's watch. No, it's not the one I want. No, I don't want you, dude. Oh. Let's see what he says.
Cardiac cath lab is a facility that has X-ray equipment, and it's designed to allow us to take pictures of the coronary arteries, the arteries that feed the heart, and most of the arteries that plug up as we get older through a process is called atherosclerosis, or people refer to as heart insurance. So the lab is equipped with a table that you lay on, and then the camera is above you and below you. It rotates, and all the equipment that we need for these procedures is available right next to the lab. When you do a procedure like that, there's 4 people that are right in the room involved in it, and 1 person in the back, which is called the control room. That's tabulating the devices we use, all the procedure rooms. So there's multiple reasons that someone might need a heart cath. The most common reason is they're having a heart attack, or they're having a lot of chest pain, which has been shown to be likely related to blockages. So the procedure is done. You lay on the cath lab table, and you either do it from the wrist or the leg. There's advantages and disadvantages to both sites. The advantage of the wrist is there's minimal risk of bleeding when you get up right away. The disadvantage, though, is much smaller artery, can spasm on you, or you can lose an elbow or your shoulder. You can't actually get to the heart. You have to get a catheter, which is a small hollow tube, and you have to thread it up through the leg, through the arm, and put it into the arteries that feed the heart, which come off just above the aortic valve, which is one of the 4 valves. So you put the catheter in there, and then you inject dye, which is iodine based, and that shows up on the X-ray machine. So that's how you do the procedure. The same labs we put in for pacemakers, so permanent pacemakers, if your heart's beating too slow, and it can be rectified by adjusting that in a pacemaker. So pacemakers, electrophysiology is a branch of cardiology that now deals with rhythm problems, and their procedures are also done in the lab. We have the ability to replace heart valves now through the groin instead of surgically, and that's done in the cath lab. There are procedures where you can block off what's called the left atrial appendage, which is the little pocket off the left chamber where clots form if you're an AFib. So that's done in the cath lab to avoid the use of Coumadin or those other blood thinners for people that are prone to bleeding. Almost all the sophisticated procedures that are done in cardiology require the cath lab.
Now let's see if we can actually see the person. I hope you heard the. Did you hear the audio of that? And could you see the video before I
No,
show?
the audio wasn't really there.
Oh well, shoot, we're not going to bother with that then. Let's go back to listen to the old fat ball guy talk here. Okay, and then CABG coronary artery bypass graft. That's bypass surgery that I just described. On pump, they open your chest. They get your pulmonary circulation is replaced with they call it a bypass machine, or
like a perfusionist.
It's ECMO, extracorporeal membrane oxygenation. There's a perfusionist running this machine. This machine oxygenates the blood, which doesn't go through the heart, and it doesn't go out to the lungs. They stop your heart, and they're not breathing for you anymore because the machine is oxygenating your blood, and the heart that they stop, now they can go do the plumbing job, right? They can plumb around the blockages, and then they start the heart back up. That is an
So, so,
on-pump CABG. Go
so,
ahead.
so pretty much the perfusion pumps just cleans your blood, right?
It takes the carbon dioxide and waste out and then adds the oxygen back in.
Okay.
So that's what the pump does. And over time, because of, I mean, you stop somebody's heart, there's a risk that you don't get it started again. It's a very remote risk. It's amazing how easy that heart is to start again. But there is a risk that the heart doesn't start again. There are other risks. The machine providing perfusion isn't the same as the body providing perfusion. So there are some associated problems that go with that. So they've started experimenting with animals, and I know people get all up in arms about lab animals, but working with pigs and primates, they developed a procedure to slow down the heart but keep the heart beating, stretch a little frame around where a blockage is, and quite often, rather than harvesting a vein to plumb around, they will just take a branch of the internal mammary artery and then they plumb that in. So at that point, circulation through that coronary artery is provided by blood that's being pumped out into that internal mammary artery, and that provides perfusion for part of the heart. And it's a shorter procedure. The chest is open, not open as long, which is a good thing. They've even perfected that now to the point that they can use robotics and do a more like a minimally invasive procedure in some places. So we don't have that yet here, but they can do a more minimally invasive CABG and do that off pump so that they're working on a beating heart and they connect either do the bypass graft with the harvested vein that they get from the saphenous vein in the leg, or they use that internal mammary artery and just reroute it. They just cut it away from where it normally, its normal route, and then they just plumb that in and anastomose or connect that and open it up into that more distal portion of that coronary artery. So that's all. More and more advances like that coming. He mentioned in the cath lab being able to replace a valve. We used to have to open the heart. We had to stop the heart, put the patient on bypass. Not we as in meaning me, because I'd love to see this, but I've never personally seen one of those surgeries, and you sure don't want me having a knife in my hand like the men and women who do that surgery. But where was I headed with that? Oh, we've progressed in these procedures and become more proficient in less invasive things. So it's replacing that valve, instead of opening the chest up, stopping the heart, cutting the heart open, getting in, replacing the valve with either a mechanical valve or a pig valve. Pig valve probably works better, but not everybody can. I don't know how you determine who's a candidate or not, but Uncle Google knows. But they determine the proper valve to put in, and then they put the heart all back together, sewed the chest up, came out with chest tubes sticking out, all of that stuff. Now they're able to go in through the femoral artery and in the cath lab and go up and remove the old valve. And I think they actually spread the old valve apart, leave that tissue there, and then release that spring-loaded new valve, and it would be and then that new valve spreads out into the heart, and it's anchored there, and it stays there. And then you have the 6 or 8 hours of recovery time from a heart cath, and then monitoring usually overnight after a heart cath, and then and especially with a major intervention like that. But so those are advances in medicine all the time. Good Lord, I know we have a couple of people in this class, and then as well as my son, who are planning to head to medical school. And by the time these folks enter their residency after medical school, and who knows what will be happening then, let alone what advances they'll see over the course of their careers. That's just that's why we practice medicine. We don't ever get it right. It's not because we always screw it up. It's because we keep finding a better way, because smarter people with more, and maybe the same intellect as doctors of 75 years ago or 80 years ago, but they have technology advances, and they have more machines and more things available that we've learned by studying the human body. All right, so we've talked about the electrical system. Yeah, let's go 10 more minutes and then take a break. Is that all right with you guys? I didn't hear any objections, so I'll keep going. We've talked about the electrical system. Each of these nodes, the SA node, has its own intrinsic rate. It beats 62, it generates impulses 60 to 100 times a minute normally. That sounds familiar, right? If it's the normal range of heart rate or pulse rate in an adult is 60 to 100. Well, dadgum, that means the SA node is carrying the day and doing its job. Then coming in behind that, if the SA node doesn't send an impulse down, then the AV node fires. It's a redundant mechanism, and it fires 40 to 60 times a minute. And then if it fails and no impulse makes it down to the ventricles say, hey, we got to save the day. We can't die here, fellas. So the ventricles, 20 to 40 is the rate as the heart rate originating in the ventricles. That won't be on an exam. So those redundancies, what in the heck? That is due to automaticity, and that is when other cells in the heart, other tissue in the heart kick in to try to keep us alive when the normal electrical impulse doesn't come. All right, so it's not as efficient. Every time you drop down, you lose efficiency and you lose perfusion. So at that 20 to 40 beats per minute, we may just be perfusing the heart and the brain, and the kidneys may be screwed. What's going to go downhill as this heart rate goes down? That good Lord, stroke volume times heart rate equals cardiac output. Cardiac output goes down because heart rate goes down. So we're not perfusing as well, not nearly as well, but we're hopefully keeping the brain and the heart alive. And then as that fails, eventually, because of hypoxia and hypercapnia is a high carbon dioxide level. Because of hypoxia and hypercapnia, the ventricular cells all get pissed off, and they start fighting to see who controls, and they start firing all at the same time, or 1,000 of them at the same time. And that looks like that fibrillating heart. And that is actually what causes ventricular fibrillation is multiple ventricular cells firing in chaos without any ordered tracing to the EKG. All right. Sympathetic nervous system, fight or flight. Parasympathetic is rest and digest. Those work in opposition to one another to balance out our autonomic nervous system. These electric impulses are governed by the autonomic nervous system. That parasympathetic slow you down, slow the heart down if it's getting too fired up and try to take off and run away and kill us. That your vagal nerve, which is one of your cranial nerves, is the primary nerve that gives us, they call it parasympathetic tone, that half of the autonomic nervous system that slows us down. Okay, myocardium has to have a continuous supply of oxygen and nutrients. Without it, heart muscle starts to die. Increased oxygen demand. If let's just hypothetically say I could still go run a mile. You've seen me walk with a cane. You're laughing right now. That's when I start to run, that increased oxygen demand, that kicks in, my sympathetic nervous system kicks in, and adrenaline causes increase in my heart rate and my respiratory rate, and it causes dilation of my coronary arteries because my heart muscle needs more blood. Remember, stroke volume is the amount of blood ejected with ventricular contraction. And we've already talked about these suckers. Cardiac output, the amount of blood that passes through the heart in 1 minute. Heart rate times stroke volume equals cardiac output. Perfusion, constant flow of blood and oxygenated blood to tissues. Remember the perfusion triangle. We have to have a functioning pump, properly functioning pump. I don't have the triangle up here, so I'm moving my mouse. Then we have to have intact pipes, properly functioning pipes. And then finally, we have to have down there on the floor of that triangle, the base of that triangle, we have to have the fluid to be pumped, right, which is blood. If perfusion fails because of a failure of one or more of the legs of that perfusion triangle, then that patient will develop shock, inadequate tissue perfusion, right? And then cellular death begins occurring, and eventually patient death occurs. Okay, 4 more minutes till I said we'd take a break. Where does chest pain come from? This is a term you need to know, ischemia. Ischemia is decreased perfusion of tissue, and specifically we're talking about the myocardium here. The myocardium is the heart muscle itself. So we have decreased blood flow, and one of the biggies we're talking about is that blockage. We have the heart muscle itself suffers from ischemia. Ischemia means actually means low oxygen level. So ischemic heart disease, that's decreased blood flow to one or more portions of the heart. And we know that the heart muscle itself has to have that continuous flow of oxygen and nutrients. Without it, those blood cells, those myocardial cells start to die. And if enough of them die, then the function of the heart decreases, and that can impact cardiac output, which, because the myocardium doesn't contract as efficiently, stroke volume goes down, cardiac output goes down, perfusion goes down, and bad things happen to our patient. Let's take 5 minutes. We'll pick up with atherosclerosis. We're about through the physiology and pathophysiology. The rest of it's going to go fast because I've already been talking about it. And then we will move into what the heck do we do for this stuff? So let's take 5, and then we'll come back and blast that stuff. Let's talk about atherosclerotic heart disease. There's a new term for you. I talked about all those cheeseburgers and all those lipids from that high fat diet, all those things I love to eat, sausage, bacon, all that stuff starts to combine with calcium, other minerals to form this plaque. And I mean, it's hard. It almost becomes part of the artery itself. It's not easy to remove. They have to grind that away in the cath lab. And so you can see normal is that wide open artery up there. This plaque, this long piece of stuff running along this narrow artery, you can see that occupies quite a bit of the lumen. Eventually, are we there yet? So we can have a myocardial infarction one of 2 ways. This could get narrow enough that a piece of a blood clot maybe makes its way through circulation and comes through the left side of the heart, and it makes its way somehow through that one of those coronary ostia, and it comes down and it won't squeeze through this. It's just that lumen of that tube being an artery is too small for that to get through. So we have a blockage there. More commonly, this plaque extends to the point that it starts to weaken this arterial wall. But an artery has 3 layers. You have the tunica intima, that inside layer. Tunica media is in the middle. Tunica adventitia is the outside layer. And eventually that plaque gets so large that it can start to weaken that tunica intima until it explodes. That pops, and then there's bleeding into that tissue, and because the body recognizes an injury that's bleeding, that triggers a clotting cascade, and that starts to form a blood clot. And as that clot forms, not only do you have that ruptured material from that plaque and that arterial wall, you also have a blood clot forming on there, and it gets bigger and bigger, and the heart muscle starts to starve for oxygen, and the part of the heart muscle, and the body says, oh man, we have to restore blood flow. We have to have our minute volume the portion of cardiac output that goes to the heart muscle itself. So the sympathetic nervous system kicks in, good old fight or flight, and that further increases the oxygen demand. We're trying to increase blood flow, but as that starts to narrow, you can start having a spasm in that coronary artery to the point that it starts to completely occlude that. And that's one of the ways. Or more uncommon, I think, would be that plaque eventually gets big enough that it completely occludes that artery. But usually it involves a rupture, bleeding, then that coagulation cascade kicks in, and it starts to form a clot that blocks that. Thromboembolism, that would be blood clot floating through the blood vessel that lodges. AMI, acute myocardial infarction. Infarction is that blockage, and then that becomes an acute situation because you have part of the heart muscle that is doing without oxygenated blood. Coronary artery disease is leading cause of death in the U.S. Everything has an acronym, so that's you might see CAD, all capitals for that. There are controllable risk factors like diet and exercise. There are uncontrollable risk factors such as genetics, race. African Americans have a higher instance of coronary artery disease, also Native Americans. There are different genetic risk factors for various different diseases in differing populations worldwide. ACS, acute coronary syndrome, that can either be angina, that classic squeezing pressure type chest pain, or that all the way up to that full-blown myocardial infarction. Hopefully you understand what the infarction part is now, that blockage. Angina pectoris, or angina, that is when the heart's need for oxygen exceeds the available supply. You have that crushing, squeezing chest pain. That doesn't mean that we have permanent damage to the heart yet. It doesn't mean that we have cell death yet. That means that there is reduced oxygenated blood flow to part of the myocardium, and that is usually during exertion. That would be classic chest pain, or stable angina is under exertion, and it's a serious warning sign. It is a preview of bad things to come. Unstable angina, that would be developing that chest pain at rest or with minimal activity, so with fewer stimuli. Stable angina is relieved by rest or nitroglycerin. Unstable angina isn't. Prinzmetal's variant angina, it's caused by coronary artery spasm. The classic presentation of that is somebody who's totally at rest, in bed asleep between midnight and early in the morning, and bam, chest pain wakes them up, and quite often that's a coronary artery spasm. I mentioned previously a time when somebody might have a coronary artery spasm that resulted in an acute myocardial infarction. Does anybody remember those super high doses of caffeine from slamming down those energy drinks? Yeah, you're seeing occasionally full-blown MI in high school kids who think it's fun to slam 2, 3, 4 of those big monster energy drinks. So can definitely be dangerous. And most people, when they're in high school, I don't know that you think you're invincible and think you can't die. It just doesn't occur to you that you could die. And sometimes it's everybody else is doing it, so I'll join in. And sometimes you just like the way something feels. People don't start using drugs because it makes them feel bad. There's a feeling there they're looking for, of whether it's a euphoria or escape or getting pumped up and having that, I feel more alive when I do meth. Well, you'll feel more alive for a little while, but you'll look like death, and then you'll eventually get dead. So we're going to treat everybody with chest pain as if they are having an acute myocardial infarction. So we don't have to distinguish between angina and a myocardial infarction. We are going to err toward caution, and we are going to treat everybody like they're having an MI. And if they figure out at the hospital by drawing blood and looking at cardiac enzymes, that our patient isn't having a myocardial infarction, then they've, by golly, sure had a big warning sign. So we're gonna save lives by treating them like they're having an AMI. That pain, the pain with a myocardial infarction, is because of the death of heart muscle cells, or myocardial cells. Good grief, buddy. Brain's got to catch up with the mouth occasionally. Not very often, as you've seen, but once these cells are dead, we can't jumpstart them and bring them back. It's not like TV where they shocked the guy who had a heart attack and died, and it's just like jumpstarting your car and it fires up and they go again. Does not work that way. This patient needs clot busting drugs called thrombolytics to break down that clot, or something we can do to help inhibit that clot. In our EMT world, they need thrombolytics or an angioplasty, preferably within the first couple of hours, to prevent major damage to the myocardium. Immediate transport is essential. Activating advanced life support is essential. If ALS isn't available, sometimes lights and siren seem to make this worse. Why? Because if without lights and siren, I don't think I'm dying. Maybe I feel like I might die, but it isn't bad enough they turned on the lights and siren, and then you turn on the lights and the siren, and then that triggers more of a sympathetic nervous response, and that takes a bad situation and makes it worse. So expedited transport without lights and siren would be preferable in a patient who's having angina. If they're having an MI and they're in cardiogenic shock and about to die on you, then we've got to scoot to the hospital. What helps you make that judgment call? Experience and further education. We already established that there's a distinction between AMI and angina, and we don't make that pre-hospitally. Treat everybody like they're having an MI, and we need to, in our sample history and our OPQRST onset, what were you doing when this started? I was shoveling snow. All right, that's good. If it's winter and there's snow out there, if I tell you I was shoveling snow today in Amarillo, Texas, you're going to question how well my brain's being perfused, right? There's something upstairs not working right. He's hallucinating or doing something. AMI, that pain's going to last longer than 30 minutes. And AMI, it's not going to, probably that pain's not going to be relieved with nitro. So we need to look at our patient's general appearance. Do they look like they're about to die? Do they look like they're in severe distress, or do they look like you or I sitting in my office having a friendly conversation? Then we need to get vital signs. You get a good baseline set of vitals. Repeat vitals every 5 minutes. What is their mental status? What are the consequences of an MI? We already talked about death, right? Cardiogenic shock, when the heart muscle starts to be damaged to the point that stroke volume goes down, then cardiac output goes down because half of our equation has changed. Congestive heart failure, that's the one ventricle or the other, sometimes both, are not keeping up with demand. They're damaged, the muscle is damaged, and not pumping the blood out. So what happens with right-sided heart failure? When we have damage to the right ventricle because of the coronary artery that was blocked, and the blood cells on the right side that lost perfusion, the blood cells, the myocardial cells that lost perfusion and died, that right ventricle isn't working as well. It doesn't keep up with the return of blood to the right side of the heart. So it's not pumping blood out to the lungs like it's supposed to. So in right-sided heart failure, you see things like swollen extremities. You see edema in the legs, sometimes back in the flank area, and sometimes even into the arms. And then left-sided heart failure, the left ventricle is damaged, and that oxygenated cardiac output supplying oxygenated blood has reduced, and the right side of the heart's still doing its thing. If it's unaffected otherwise, it's still pumping blood out to the lungs, and it's in that oxygenated blood's trying to return to the left side of the heart, but the left side of the heart can't keep up, so the system backs up. The plumbing backs up into the bathtub and the sink and all over the floor, but we don't have sinks and floors and bathtubs in our body. So if the left side doesn't keep up and we have left-sided heart failure, that backs blood up into the lungs, and you get wet sounding lungs. You can actually, as the inspired air moves down into the lungs, it moves through liquid, and you can hear a change in lung sounds up to the point that it almost sounds like it's bubbling. And then and cardiac output goes down, perfusion goes down, patient gets tired real easily, and as that blood continues to back up into the lungs, it starts being pressured out of the capillaries and eventually out into the alveolar sacs, and then maybe up into the bronchioles. And defense mechanism, the lung says, crap, we have liquid where we're not supposed to. So that triggers the reflex to start coughing, and maybe they're coughing up this kind of foamy, frothy, pink colored sputum. Sputum is spit, right? So it's oxygenated blood. So you have this real kind of pink, foamy colored stuff, and that interferes with oxygenation as that's out in the alveolar sacs, and your patient almost just drowns in their own fluid if something isn't done to help them. All right. Dysrhythmias, if damage to the heart affects the SA node, the AV node, the part of that conduction system that we talked about, it may trigger little extra electrical complexes in the ventricles that we call PVCs, or premature ventricular complexes. It doesn't always mean there's a contraction. It doesn't always generate a pulse. Come to paramedic school, teach you all about that. Tachycardia, it could cause the heart to beat faster than that 100 beats per minute in an adult. Or if the SA node is damaged, it can cause profound bradycardia, that heart rate way below that 60, so that maybe our patient starts having syncopal episodes or altered mental status. And how do they fix that? They put a pacemaker in, if we catch it before it kills our patient. Okay. Defibrillation, your book says restores cardiac rhythms. Actually, it's a reset for the heart. It shuts everything down. It stops all this extra, hopefully stops all these excited myocardial cells that are just firing out of control, shuts it all down, hopefully long enough for that strong impulse from the SA node to jump back in and start taking over and to begin pacing the heart again. Asystole, A means without, systole means contraction. So asystole, the absence of systole, that is the absence of all electrical activity. That reflects a long period of ischemia. That's the old flat line on the EKG, and almost all of those patients die. We may be able to briefly resuscitate them, but usually there's such profound damage that you don't get them back. The ones that we save are the ones who almost go into cardiac arrest, or the ones we catch quickly. For every minute of time in cardiac arrest, the chance of survival goes down by the chance of defibrillation and return of spontaneous circulation to our patients goes down by 10% every minute. Okay, cardiogenic shock, I've just described it. That decrease in cardiac output because the stroke volume of the heart goes down, so we're not perfusing the body because the pump itself is damaged. Remember, I'll move my mouse in a triangle. You can all see that perfusion triangle. We still have intact pipes. We still have the same amount of blood we had before, but the pump is damaged and it can't put out as much. So that decrease in the function of the pump is what we call cardiogenic shock. Congestive heart failure, I just talked about because I got ahead of myself. That's okay. We move faster through this slide, but often it doesn't occur immediately. Sometimes it takes some time following an MI before the congestive heart failure manifests itself. Occasionally it's happening right now in front of you. But. Okay, we're going to hit hypertensive emergencies, and then we'll get down to how do you treat these things. Because we need to know, start thinking MONA. That's, except for EMTs don't administer morphine, but we treat, I'll just go ahead and talk about it. We treat angina with MONA, meaning morphine, oxygen, nitroglycerin, and aspirin. As an EMT, it's outside your scope of practice to administer the morphine. So MONA has a sister who's almost as friendly to the human body as MONA is, and that sister is called ONA. And ONA is oxygen, nitroglycerin, and aspirin. Oxygen to increase the available, the oxygen concentration in the blood so that hemoglobin has a lot more there to pick up. So there's that we've moved a lot more oxygen through that alveolar membrane, and it sits out there in that capillary blood for the hemoglobin to pick up. And if there's a lot more of it available, hopefully the hemoglobin's going to pick it up, and we're going to increase oxygenation. If we increase oxygenation, that provides more saturation of hemoglobin, which gets more blood to the heart muscle, right? So we may have a blockage that's decreasing the amount of blood that makes it downstream from the blockage. But if we increase the amount of oxygen saturation, then we can help save some of that tissue. Nitro, why do we use the nitro? To blow them up? No, we don't want to blow them up. We use the nitro because nitroglycerin is a powerful vasodilator. So pre-hospitally, we can't fix that plaque. We can't do anything about that. But if we can make that vessel larger, if we can increase the lumen of that coronary artery, our patient can move more oxygenated blood past that clot. So that's a temporary fix that helps resolve some of that chest pain by increasing perfusion to the myocardium. Why do we use aspirin? We don't use it for the pain. We use the aspirin because it inhibits platelet aggregation. So, and this isn't what it is, but you're going to get a better mental picture of it, I think, if I say this. If we could say that that clot that's being formed is like getting a big old scab in there, because we can all picture a scab that we kind of associate with stopping bleeding. That if we can inhibit the platelets that are sticking together to help stop this bleeding, if we can keep those suckers from sticking together using some magic substance, then we can decrease that clot formation, and we can help maintain blood flow through that coronary artery until something can be done to fix it, either in the cath lab with a stent or in surgery by doing coronary artery bypass graft. We either do CABG or they can fix it with a stent in the cath lab. If we can just do something to keep that from sticking together until they can get in there and permanently fix the problem, our patient's going to do better. So that's why we use the aspirin, to keep the platelets from sticking together. Okay, now you're going to hear the treatment twice. Why? Because it's important, right? Tired of hearing me say that? I'm tired of saying it, but I say it because it's important. Hypertensive emergencies. There are times you're going to find a patient with a systolic pressure above 180. That is a hypertensive emergency. They can have a sudden severe headache. That is a big warning sign. We'll talk about, that's a big warning sign of maybe a stroke headed their way, that we'll talk about in the next chapter. This should be with the next chapter, but we may see altered mental status. We may even see pulmonary edema going along with this. That's fluid accumulating in the lungs. Untreated, that can lead to a stroke or dissecting aortic aneurysm. Anybody in here ever dissect a worm or a frog in biology in high school or college? Dissecting aortic aneurysm, think of that big old artery, that big garden hose tube running down through the abdomen, starting up there at the aortic arch, and then coming around through the chest, down through the abdomen. It seems most often that you see these aortic aneurysms in the abdomen, abdominal aortic aneurysm, a AAA, they also call it. That seems to be where pressure over time starts to weaken that garden hose of an artery that in the abdomen. Has anybody ever seen a garden hose with a big bulge sticking off of it? What do we know when we see that? That sucker's about to blow. We're about to need a new garden hose. Well, we don't just go down to Sam's and buy a new aorta. So we have to, either our patient dies or a vascular surgeon has to go in there and fix that. But that, just picture that a big bulge off of that aorta where it's about to blow if something doesn't change, and that prolonged untreated hypertension can cause a weakening of the aorta. We need to quickly and safely transport these patients to get some definitive care for them, or call for ALS. They have a few more toys in their bag of tricks. So dissecting aortic aneurysm, what normally happens is that tunica media starts to get weaker, and that causes that tunica intima to start to push through the tunica media, and then the tunica adventitia, that outside layer, starts to cause a bulge in that. Over time, that can become weak enough that it starts to tear. That is the dissection, when it starts to tear. What do you see there? You see a sudden onset of a severe tearing pain. And they'll tell you it feels like something is tearing my guts out, and it just hit me all of a sudden. And you start to palpate their abdomen as you do your full head to toe physical examination, which I don't think in medical cases your book emphasizes enough, but you're palpating that abdomen And sometimes you can feel a pulsating mass in their abdomen that for some reason seems to match their heart rate. This is a bad sign. They need a surgeon. We need to get them some help. All right. Sorry about that. My dog. So let's distinguish between the signs and symptoms of acute myocardial infarction and a dissecting aneurysm, because I think that will help you see what the signs and symptoms of this aneurysm are. Quite often, AMI comes on gradually, and the symptoms build as you go. Dissecting aortic aneurysm, bam, it hits right now with maximum onset. It's the full-blown deal from the start. That sharp tearing pain that it could be in the chest, because up where the subclavian arteries come off the aortic arch.
We can't hear you, buddy.
Oh, what happened? Can you hear me now? Well, let's see.
I can hear you.
Okay. Got me now? Okay. You have that sharp tearing pain. It's maximum from the start. If it's in the aortic arch, the tear is oftentimes right where the subclavian arteries come off, and there's kind of an inherent weak place there. It doesn't slow down. Chest pain with an AMI, it kind of, call it waxing and waning. It gets really intense, then it backs off a little bit, then it gets really intense. With an aneurysm, it doesn't slow down. It just keeps hammering at them. And with an aortic aneurysm, often there'll be some radiation that goes through to the back. It's kind of an anterior to posterior radiation. Radiation with an AMI, you think of radiation with that, you have that squeezing chest pain right in the middle of the chest, right there kind of beside the left nipple. They'll make a fist and hold their hand like that and put it on their chest. That's called Levine's sign, Dr. Levine, Levine''. Levine's sign. They have their fist squeezed and put it on their chest. They're telling you, I have that squeezing chest pain, and it goes to my jaw or down my left arm, sometimes into the epigastrum right there, like the below the distal end of your sternum, that gut pain. Did part of you lose me here? Okay, I think we only have one without sound. I don't know what happened. Leave and come back in, and I'll watch to punch you back in. Hopefully. Okay, I'll keep an eye on that. And then here's a big deal. This is a great big deal. You have peripheral pulses ×4 in a patient who's having an AMI. I'm going to tell you right now that in any patient with chest pain, I want you to take blood pressure in both arms and see if there's a difference in the blood pressure between the two arms. If there's a difference in blood pressure between the two arms, that is a sign that there is a dissecting aneurysm. If that dissection is more distal, further down the aorta, moving down toward that bifurcation into the right femoral artery and the left femoral artery, you will have unequal femoral pulses. So in our patients with chest pain, we want to take bilateral radial pulses, see if one's stronger than the other. We want to take bilateral blood pressures to see if one is lower than the other. And we want to palpate bilateral femoral pulses to see if there's a difference in the femoral pulse, because that can be the sign that our patient may have a dissecting aneurysm. Okay, now we're ready to go through treatment here. All right, this is a nature of illness situation. We're going to go through this pretty quickly. General impression: are they sick, not sick, fixing to die, not fixing to die? Airway and breathing, we're just working right through that algorithm, right? If their O2 sat is less than 95%, we're going to start with O2 via nasal cannula. This is a big change in pre-hospital treatment, well, emergency treatment across the board. If our patient has an O2 sat of 95 or above, we don't, unless our protocol requires it, or online medical control tells us to put oxygen on anyway, we don't provide oxygen. Research has shown that in patients who are having a myocardial infarction, that infarction, because of oxidation, and that's beyond the physiology and pathophysiology of this course, but because of oxidation, having too high of an oxygen level, unless it's just natural, but supplemental oxygen, when our patient has 95% or above in O2 saturation, that extends the infarction and makes it worse. And that's a big change in our treatment. All of them used to get O2 via non-rebreather mask at 15 liters per minute. Now we only go to that if their O2 sat is below 95, and they don't improve quickly with the nasal cannula. Don't waste your time going 4 liters, 5 liters, 6 liters. Just go straight to the big guns and get to that non-rebreather mask. If breathing is inadequate, don't jack around. Get going with your BVM with 100% oxygen. If their rate's out of whack, their breathing's too shallow, and their O2 sat is below that 95, and we're not seeing improvement, or their rate's extremely slow, it's extremely fast, or it's extremely shallow, move straight to that BVM with 100% O2. If they have pulmonary edema, that pink frothy sputum that I was talking about, first we can go to CPAP with them if they're conscious and they can follow instructions. If CPAP isn't indicated, if it's contraindicated, we're going to move to that BVM. Or if CPAP isn't available, or if you're in a system where EMTs aren't allowed to touch the CPAP, then we're going to go straight to that BVM. Okay, transport in a stress relieving manner. I should have highlighted that. That is, like I said, we don't want to further hammer that sympathetic nervous system, increase their oxygen demand of their myocardium, and make their condition worse. So we're going to get a sample history. Medications can be a big indicator of any underlying heart disease. Maybe they have nitroglycerin of their own. If they've taken their nitro and it hasn't worked, just ask them, did it burn under your tongue, or did it make you lightheaded? If they say no, we're going to move directly to our nitro. Theirs was no good. Work through that whole sample history, just like we've done since we first started working with patient assessment. Onset, extremely important. Provokes or palliates. Why is that important? We said that angina, stable angina, rest would relieve chest pain. So I'm shoveling the snow, I have chest pain, I stop, I sit down and rest, and it goes away. Then I start shoveling again and it comes back, and then it goes away. And if I don't get some help, then bad things are going to happen. Quality, is it a burning pain? Is it pressure? More often they're going to describe cardiac chest pain as pressure or squeezing, elephant sitting on my chest. Somebody parked a Mack truck on my chest. I don't know. You hear various descriptions. Radiation. Sometimes they just have that squeezing retrosternal chest pain. Sometimes they have the radiation into the arm or into the jaw, epigastric pain with it. Occasionally, with an inferior MI down there on the lateral side of the right ventricle, because the heart kind of tips and sits with the right side more down. That inferior wall MI a lot of times will trigger some nausea and vomiting. That takes a bad situation and makes it worse too. Severity, that's your 0 to 10 scale. Time, when did this start? Okay. Other things to ask. Is it worse when they lie down? Is it better when they sit up? Do they have shortness of breath with it? Do they have a cough? If they have a cough with it, is it a productive cough? Are they coughing up that pink frothy sputum that I was talking about? Are you coughing do you have a cough? Yes. Are you coughing anything up? Yes. What does it look like? Looks kind of foamy and pink. Uh-oh. This is worse news than a what. Don't tell them that, but get on the stick. Don't stay and play with these people. You've got stuff to do, and they need definitive care at the hospital. Nausea, vomiting, fatigue, headache, palpitations. What is that? I feel my heart beating in my chest. It feels like it's about to beat out of my chest. I feel my heart flip-flopping. You hear all kinds of descriptions, but that's noteworthy. Take note of that. Be sure to put that in your documentation. Be sure to convey that to the hospital. Have they had any recent chest trauma? Maybe they're having a trauma-related event, and it's not purely cardiac in origin. Have you ever had a heart attack? Has anybody ever told you have heart problems? Are you a smoker? Do you not smoke? Do you use on the medications? Do you use any supplements or any street drugs? I'm here to help you medically. I'm not here to pass information along to the cops so I can get you arrested. Don't worry about that. But it's important that I get honest information from you so we can provide the best help for you. Consider ALS early. Like I said, there are additional things. There are a patient who is in cardiogenic shock. A paramedic can administer a medication to make the heart muscle squeeze harder. It's called a positive inotrope. Makes the heart muscle squeeze harder. And if it squeezes harder, stroke volume goes up, right? Stroke volume goes up, cardiac output goes up. So that's what we're shooting for there. Q5-minute vitals. We're going to want to reassess that patient every 5 minutes. Sudden cardiac arrest is always a risk. So monitor your ABCs frequently, and don't leave the AED in the box over there so you have to crawl in a cabinet to get it. Sit it on the squad bench beside you. Put it somewhere handy that you don't have to put the monitor or the pacing pads on them yet, but have it handy just in case, because if they go into cardiac arrest, we're going to do CPR until we can get that AED fired up. And the quicker we apply that AED and defibrillate them, the better chance we have of restoring spontaneous circulation. So, okay. Position of comfort. Most of these patients are going to want to be in a high Fowler's or semi Fowler's position. What the heck is that? High Fowler's sitting straight up and down 90 degrees. Semi Fowler's is kicked back more to 45. I talked about MONA, morphine, oxygen, nitro, and aspirin. put an X through morphine until you get out of paramedic school. Now they're actually replacing, there's a better looking sister called Fona that we're starting to date instead of Mona, and we're using fentanyl instead of morphine most places. Oxygen, nitroglycerin, aspirin. Oxygen, we talked about keeping that O2 sat at that 95% or above. We're not going to supplement if it's already 95%, but we're going to watch for a drop in that O2 sat because this can change quickly. And if it changes, you need to get that intervention of oxygen going right now. Nitroglycerin. What do I want to tell you about nitro? If they have systolic blood pressure below 100, we can't administer nitro. Remember, when we talked about the human body, we talked about preload, and that's the amount of pressure in the system during diastole. Preload is what gets blood flow back to the right side of the heart. And if preload goes in the dumper, cardiac output goes in the dumper because we're not moving blood through the system into the left ventricle. And we're going to dump preload if we give them nitro when their systolic blood pressure is already below 100. So always watch that systolic blood pressure, and you can't give the nitro if their systolic blood pressure is below 100. Or remember the other question we have to ask back there with medications, do you use any erectile dysfunction medications? Or maybe another question, because I told you how we wound up with Viagra, Cialis, and all that stuff, is it was developed to treat pulmonary hypertension, that high pressure in the pulmonary arteries that decreases blood flow out to the lungs for oxygenation. They may be taking, you may have a little old lady who takes Viagra tablets for pulmonary hypertension. So we've got to find out about those meds and find out if they take, or if they use a supplement. What's the time frame on that? If they've taken one of those erectile dysfunction meds or a drug for a nitrate, which is what Viagra, Cialis, and Levitra are. Those are nitrates like nitroglycerin. They're powerful vasodilators. If they've taken one within 24 hours of the time we want to give nitro, it's contraindicated, absolutely contraindicated in the EMT world. Come to paramedic school. We'll teach you how to give it if their pressure is below 100 and what to do to fix it when you do. All right, and aspirin we talked about, that inhibits platelet aggregation, so that inhibits the extension of that clot that's trying to block off that coronary artery. All right. So that would be low dose aspirin. That would be 324 milligrams. That's 4 baby aspirins chewed and swallowed, or 1 full-blown adult aspirin chewed and swallowed. That tastes horrible, but unless you're weird like me and you like the taste of aspirin, that would be 325 milligrams if you just have the 1 adult aspirin. It's the concentration that you're provided. As an EMT, you can assist them with their nitro if it's indicated, if it's not contraindicated, just like we've talked about, or if you may have a protocol that allows you to administer nitro in the appropriate situation. Questions about treatment? Okay, we're going to spend a whole lab on administering well, nitro's one of them, but make sure it's not expired. What do we go through? Those 6 R's, right? Or the 5 R's, I mean. And then if you're assisting them with their meds, we need to make sure that medication is prescribed for them, not for their wife, their brother, their cousin, Fred, or their kitty cat ginger. Wear gloves so that you don't absorb that nitro yourself. EKG, I'm going to bounce through. I've talked about what they are and what you're doing. You're going to be assisting a higher level of healthcare provider with EKGs, so we're not going to spend a lot of it. You have to have good electrode placement, and it has to adhere well to the skin. So you may be shaving body hair off of Aunt Fanny's chest so that you can have good electrode contact. Our classic chest pain presentation patients, they may be very diaphoretic. They're very sweaty, and it may be really hard to make those electrodes stick. Your book has this picture of where you put the electrodes. Some people call them stickers, but we're professionals, so they're electrodes. These go in specific places. I'm not going to spend any more time about that. They will teach you how to use that equipment. You don't have to worry about knowing in advance. We've talked about CABG. We talked about heart casts. What is that? Percutaneous transluminal coronary angioplasty. That's getting that small balloon in there where they go through the radial artery or the femoral artery and get that catheter tip up there by those coronary osteas so that they can get the dye in, figure out where they need to put the balloon, and scrape away and blow that balloon up. Okay, if somebody's had CABG, this is going to change because they're doing more and more of the minimally invasive cardiac procedures. But in the past, there was a big scar down the sternum where they filleted them and opened up so they could get in there and see this stuff and fix it. Some patients have pacemakers. I talked about why somebody would need that if they have a very irregular rhythm or they have a rhythm that's too slow. They can insert a pacemaker. You have a little device like that. Most often it's on the left side up there right below the clavicle, like the middle of the clavicle. They make a little pocket in the muscle there. They hollow that out, and that thing sits there with wires or electrodes that go out to the myocardium to do the pacing. Also have implanted defibrillators, ICD, implanted cardiac defibrillator, as opposed to an AED. And that recognizes certain rhythms in the heart and defibrillates. More often now, you're going to have, when they put in a pacemaker, they may go ahead and put in the electrodes for an ICD also, and they just connect to this little control box with a computer terminal, a small handheld computer terminal, and they can turn on the defibrillator function. And could be that there's a reason that they have to delay putting the internal cardiac defibrillator in, and during that time they may have that patient wear a defibrillator vest, also called a life vest, and it's like wearing an AED around in a vest, and it monitors heart rhythm, and it will deliver a shock if it recognizes a heart rhythm the same way that an AED will. We leave that vest in place unless it interferes with doing chest compressions. If they have a life vest on, that external defibrillator vest. LVAD, that's a booster pump. That's a left ventricular assist device. It boosts the output with stroke volume to help increase cardiac output. Some of them just constantly put pressure. Others kind of pulse. Patient or the family can tell you more about that. For years, they said, if they have an LVAD, we don't do chest compressions. The more recent literature, go by your protocol or go by what online medical control tells you. but within the last 4 or 5 years, well, since the publication of your book, they've determined that chest compressions increase the percentage chance of survival by 50% with someone with an LVAD, and it works off the one reason to contact medical control. It goes off of their mean arterial pressure and what their PCO2 is. So, okay, last disorder, commotio cordis, a sudden major blow to the chest, and you see this more often in athletes. You see kids playing Little League baseball, or a goalie in hockey, or someone else. Goalie's going to have more protection. You see maybe just someone playing hockey or someone in martial arts get a sudden blow to the chest, and if it comes in the right place when the ventricles are repolarizing and getting ready to receive that next impulse, if it falls in the right place on that T wave, that repolarization of the ventricles, that immediately sends the heart into ventricular fibrillation. The person goes into cardiac arrest with immediate defibrillation, almost 100% survival rate. You have younger, more healthy person who went into cardiac arrest right in front of you. So if they have immediate CPR and somebody grabs an AED really quickly, they can defibrillate them, and they're talking to you, and maybe you don't even want to go to the hospital. But you need to strongly encourage them or their parents to allow you to transport them to the hospital. Cardiac arrest, you know what to do for that. You know what an AED is. You know how to use it. Cardiac arrest while you're transporting a patient. When do you call ALS? I'm going to tell you, all of these patients who present with acute coronary syndrome, if ALS is available, you need to call for them. Your book says blood pressure below 90. We have to watch glucose levels, yada, yada, yada. It's better to have them in the hands of someone who's capable of using all the interpreting EKG, using all the appropriate medications, taking care of the patient. Check the batteries on your AED every day at shift change. Make sure you have electrodes. Make sure the defibrillator pads, make sure they're good. If you're going to defibrillate a patient, get them out of pooled water. Get them. If they're touching metal, you better not be touching it, or you're going to get you could possibly have same situation as commotio cordis. All right. During transport, if the patient goes into cardiac arrest, you need to have the driver whoever's driving, have them pull over, get in the back to help you with CPR and getting the AED on the patient. Call for ALS. If they're not available, you need to call for extra hands, because somebody's going to have to help you do high quality CPR on the way to the hospital. So if you get a question on an exam that says you're transporting your patient with chest pain and they go into cardiac arrest, you do all of the following except, or whatever the question is. Pulling over is one of the major things. You have to pull over so you can do CPR and get the AED. If you don't have an AED and you're close to the hospital, do high quality CPR, get them to the hospital. If ALS is available, get ALS there. Don't delay defibrillation. Don't wait for ALS to do anything. I have this AED, but ALS can be here in 3 minutes. Well, we just said that the chance of resuscitation goes down 10% every minute. So let's get somebody there. All right, that is the end of that chapter. Let's stretch for 5 minutes. We're going to come back and talk about strokes. Oh, I should have said questions, huh? Any questions? All right. Neurologic emergencies. What are we going to talk about with neurologic emergencies? We're going to talk about strokes, TIAs, which is the rest of the world
Are you
calls
there,
me.
buddy?
Yep. Can you hear me? Can anybody hear me? I'm unmuted. I don't know what's happening.
Yeah, I can hear you.
All right. Well, dang it. Corey, I don't know why you keep losing me. I'm talking about seizures, status epilepticus. What is that? That's just one seizure after another that sometimes can go on for 30 minutes or more. And headaches. All right. You're saying this is a headache. And why did you leave so little time for neurologic emergencies? Because we needed to spend more time on cardiac. It's just a few big things we have to know here other than managing airway, breathing, and circulation. And one thing we need to absolutely know with history. And other than that, and I will, if you keep losing sound or getting bumped off because of an internet connection, I'll get this as soon as I can get this converted to MP4. I'll get it up on that YouTube channel for you. Okay, seizures and altered mental status, things that cause seizures. Recent head injury, prior head injury, brain tumors, of course, that can cause seizures. Certain metabolic problems can cause seizures. Fever, high fever, sudden spike of a high fever, particularly in kids. Some people have a genetic disposition to have seizures. Okay, altered mental status. Real quickly, these are obvious. I think I'm going to give you an acronym to use for this in just a minute. Things that cause altered mental status: intoxication, head injury, hypoxia, stroke, metabolic disturbances. We know about the parts of the brain, right? Why are we talking about the physical parts of the brain right now, the anatomy of the brain, when we're talking about neurologic disorders? If our patient has a stroke, how that stroke affects them and what signs and symptoms they exhibit when we assess them has to do with what part of the brain is losing circulation, and that determines what effect somebody has from a stroke. Do they have a memory problem because of a stroke that affects their temporal lobe? Do they have a personality change because they have a stroke and blood flow is lost to their frontal lobe? Did it affect their cerebellum so that they have balance problems? And it all depends on what artery is blocked or ruptured. Brainstem, we know already, controls breathing, blood pressure, swallowing, and pupil constriction. Cerebellum, that's muscle and body coordination. Some of us have a better cerebellum than others. We have right cerebral hemisphere, left cerebral hemisphere. That is the division of the right side of the brain. The left side of the brain, we have crossover motor-wise, so that the right side of the brain controls motor on the left, left controls right. Sight is controlled in the posterior portion of the brain. 12 pair of cranial nerves. Cranial nerves, I think we already talked about this, but that's more of a direct connection. That doesn't run through a series of nerves. For instance, the spinal nerve that exits at the spinal cord at the level of a vertebra and goes out maybe to control your hand. That this is directly wired, and that's everything from cranial nerve 1, which is your olfactory nerve, which is your sense of smell, to, and then your optic nerve. It just works through on old Olympus, towering tops, a fin and German viewed some hops, I think is the acronym I learned anyway. Foramen magnum, that's the big hole in the base of your skull where your spinal cord exits, right? And then we have spinal nerves at the level of each vertebra. See if that's one of you texting me or if that's somebody else. Okay. All kinds of different neurologic disorders, way past the scope of this course, way past the scope of EMS. I think one of the neurology is a subspecialty of internal medicine. So you do an internal medicine residency, and then you apply to do a neurology residency, and it is very involved, very intricate subspecialty, dealing with disorders of the brain and the nervous system. So it's way past what we do. Let's start with the brain. Is we've talked about from day one, it's very sensitive to drops in oxygen level and glucose, as well as temperature, very tight operating range that has to be maintained. And if not, then the mental status is going to suffer. That's going to bring about altered mental status. A few things we can determine pre-hospitally. Many have to be determined with extensive lab work at the hospital, diagnostic imaging, all of those things. Okay, here's your general rule, and I think this is probably pretty solid. If the primary problem is connected to the heart and lungs, the entire brain is affected. That's when you have that altered mental status. Perfusion has gone down, right? This is tied to perfusion, providing oxygen and nutrients to the brain. If the primary problem is in the brain, then only part of the brain is affected generally, not the entire brain. There are exceptions to that rule. We don't need to worry about them yet. Headache, most common neurologic complaint out there. It can range from, I have a tension headache because Buddy makes me read all this stuff, and then he lectures for 4 hours. It makes my head hurt. That's a legitimate complaint. That's a real headache, right? Ranges up to, I have a migraine. Migraines are vascular headaches that have to do with one of the causes is decreased blood flow, various triggers to bring on a migraine. That's a major headache with visual disturbances, nausea, those kinds of things. We'll hit briefly in just a second. Only a very small percentage of headaches are caused by a serious medical condition. A migraine would be one. Those are incapacitating. Sometimes put people in bed for days. Medications are coming along that are better and better with managing migraines, but we have yet to be able to definitively treat the cause of most migraines. When would a headache be life-threatening? If our patient is having a hemorrhagic stroke, they had an aneurysm, that weak place in an artery that supplies blood flow to a portion of their brain, and that ruptures. You have a sudden onset of the worst headache I've ever had in my life, and they start to have altered mental status. They go downhill quickly. Some proceed to cardiac arrest rather quickly. My own paternal grandfather died of one of those, and my maternal grandmother. What does that tell me? On both sides of the family, I may have a predisposition to have a hemorrhagic stroke. So they started me on a an antihypertensive before I ever had a chance to become hypertensive, and they try to keep my blood pressure a little on the low side. Not that you came here to find out about me, but there are people who have genetic predisposition for certain things, and they can't rule that out with somebody who has a family history like mine, particularly on both sides. So they're really careful with that. Tension headaches, that's a muscular headache. That's muscles tense up, and that puts pressure on nerves, and that causes pain, often connected to stress. It's a squeezing, dull ache. Sometimes it can be really intense. I'm thankful I don't suffer from headaches, but if you do, you have my sympathy. And that even a tension headache can just be horrible, can interfere with your daily activities, your ability to read and concentrate, all those things. They don't require life-saving intervention, but they may require medical attention to deal with whatever the trigger of that headache is. There are, like I said, many causes of migraine headaches. One of them is thought to be vasoconstriction in the occipital lobe, which that decreases blood flow, and that decrease in blood flow to the brain causes pain and symptoms. It's a pounding, throbbing, pulsating heartbeat headache that I feel every heartbeat that I have in my head. I'm nauseated. I see auras around things. I have diplopia, double vision. I have blurred vision. Those are the things that you can see with that your patient with migraine. Those are signs and symptoms that they will exhibit that can last hours to days without appropriate medication. Sinus headaches, that's inflammation in the sinuses, usually the frontal sinuses up here above the eyes or down in the zygoma. Those are pressure headaches. That inflammation puts pressure on nerves and causes the problem. Okay, hemorrhagic stroke, that's bleeding. Brain tumors, that can also cause headache. Meningitis can cause a specific type of headache. That's either caused by virus or bacteria that inflames and irritates the protective layer around central nervous tissue, meaning the brain and spinal cord, and that can cause headaches. Has other associated symptoms that we'll talk about later talk about it in pediatric chapter. We become extremely concerned if our patient tells us they had sudden onset of the worst headache they've ever had in their life, and they have weakness on one side, they have facial droop on one side, and they have slurred speech. If they're still conscious even, we're thinking, holy smokes, our patient's having a hemorrhagic stroke right in front of us. I can't fix this. They need a neurosurgeon, somebody to cut their head open and go in there and fix that thing. That's with a hemorrhagic stroke. That works very similar to what we'll talk about, increased intracranial pressure, the signs and symptoms that causes with head trauma. So we're not going to spend a lot of time on that right now. We'll talk more about increasing intracranial pressure. Then can't teach the whole course in one day. Mini strokes. No, we're not ready for that. A stroke we call a CVA, a cerebrovascular accident. CVA is what it's still called. That may change. So far it hasn't. What's happening? There's interruption of blood flow to one area of the brain, which results in loss of brain function, which manifests itself in different ways in in our patient, they present with differing signs and symptoms depending on what portion of their brain is being deprived of oxygenated blood. Two types of strokes: ischemic stroke and hemorrhagic stroke. Fortunately, as far as treatment goes, if we catch it in time, ischemic strokes, or that blockage, think of that heart attack that we just talked about, that blockage from that atherosclerosis that also operates in the brain, and that plaque builds up until someday it completely blocks blood flow, and we start to see signs and symptoms with our patient. That comprises 80%. Can be a thrombolytic stroke or an embolytic stroke. We can't tell the difference in the field. Thrombolytic stroke, that would be that plaque builds up, it ruptures, and then that after that ruptures, we start to have coagulation, and we also start to have some spasming of that cerebral artery that's affected, and that cuts off blood flow. Or it can be an embolytic stroke where we have let's say somebody has atrial fibrillation. Their atria just kind of quiver, and it doesn't send good organized signal down through the heart to cause the atria to empty into the ventricles, and then the ventricles to contract during systole, and blood kind of sludges and starts to accumulate up there in the left atrium, and then some breaks off and it makes its way through that mitral valve into the left ventricle. It's ejected into the aorta, makes its way around the aortic arch, and bam, it goes up one of the carotid arteries, and it goes up till it gets into a vessel in the brain that is too small for it to continue, and then it blocks blood flow below that. So that is, if that's caught early enough, those can be treated medically rather than surgically. And if we let it go long enough, it just can't be treated at all. The patient just permanently is debilitated based on what portion of the brain died. Okay. There you see it. There's the clot, and that big chunk of brain over there on the right parietal lobe, the posterior portion of the right parietal lobe, it looks like, is doing without oxygenated blood. In other words, it is not being perfused at all. Hemorrhagic stroke, we're talking 13% of strokes. Fortunately, it's not a large amount. If it impacts you or one of your family members, it is a catastrophic deal. Statistically, your likelihood of having that is not nearly as high. That's bleeding into the brain. Those cerebral hemorrhages or hemorrhagic strokes are quite often fatal. People at high risk would tend to have very high, they would have very high blood pressure for a long period of time. They would have untreated hypertension, poorly managed hypertension. I have the medication, but I don't like taking it because I don't like the way it makes me feel. Or it kind of interferes with the job that my meth does if I take that, so I don't want to take that. Whatever the reason, they don't manage their hypertension, and that starts to weaken those cerebral arteries. And as they weaken, that aneurysm forms back to that big bulge on the side of the garden hose until someday she blows. How do we know that? Our patient describes that sudden onset of the worst headache they ever had in their life. Or bystanders or family members say he just said all of a sudden he had a really bad headache and then he done fell out. That's a DFO syndrome. Done fell out. He just lost consciousness, and here you have him. And there you can see what happens when that aneurysm blows. This is a cerebral angiogram probably that's color enhanced, but that is probably from a CT scan, CAT scan, and put the dye in, inject that radio opaque dye, and it's usually iodine based. Maybe not as much these days. They have others, but they colored that in this picture so you could see that bleeding, and then we lose perfusion. Sudden onset of the worst headache they ever had, or a very severe headache. Otherwise healthy young person often. My own grandfather was 49, as were 4 of his brothers when they died. My dad was happy to see 50. I kind of laughed at Dad and thought, well, that's really superstitious, until I was turning 49. Then I was happy to see 50. All right. Surgical repair is required if your patient makes it that long. TIA, that's our warning sign. That is called mini strokes that have that atherosclerotic atherosclerotic disease of the arteries feeding the brain, or there's a small blood clot or a series of small blood clots that the body is able to deal with, but your patient exhibits signs and symptoms of a stroke. We'll talk about what those are in just a minute, but can we tell pre-hospitally if it's a TIA? No, we can't. We cannot go shoot some contrast in our patient's vein while we're doing a CT scan and see if there's an area of the brain that's not being perfused, or we can't visualize any problem like that with our patient. So in our world, we're going to treat everything like it's a stroke, even if it ends up being a TIA. How do we know if it's a TIA or not? It resolves itself within 24 hours with no actual death or brain tissue. So that requires something beyond what we do. That's why we need to encourage all these patients who exhibit signs and symptoms of a stroke to allow us to transport them for evaluation. Every TIA is an emergency. Tell your patient, I'm feeling better now. Well, this is what we saw when we got here. This is what your family described to us. This is a big warning sign. I'm not saying you're going to have a stroke, but people who have these signs and symptoms frequently go on to have a stroke. So let's get you checked out by a doctor. Screw you, get out of my house. I've been told that a bunch of times. 2 days later, I'm back and they have had a stroke. 2 weeks later, I'm back and they've had a stroke. So signs and symptoms of a stroke. I'm going to give you a test to do pre-hospitally here in a minute that's going to give you an idea, but let's talk about facial drooping. Facial nerves are affected and you lose muscle tone on one side of the face and the corner of their mouth kind of droops down like that. And maybe they have numbness and tingling on one side or the other of the body, and maybe their arm and leg are weak, or maybe they just flat can't move them or use them at all on one side, and their speech gets slurred. Sounds like Saturday night in Borger, Texas in high school to me, except for the facial drooping part maybe. But not everybody I went to high school was having a stroke. Some Saturday nights you couldn't tell. Sudden loss of vision in one eye. All this depends on what part of the brain's being affected by having decreased perfusion because of lack of blood flow, right? Blurred vision, double vision, difficulty swallowing. That's dysphagia. That I can't, and maybe they're drooling on one side of their mouth. They decreased level of consciousness, slurred speech. Aphasia, they're having difficulty expressing themselves. They can't find the right word. You hold up your ink pen and you say, tell me what this is, and they say football. Well, either they never learned what a football or an ink pen is, or they may have expressive aphasia. Their brain is thinking ink pen and their mouth ends up saying football. You speak to them and maybe this person has a PhD in English. They have mastered the English language better than any person on the face of the earth. But they've had a stroke, and they develop receptive aphasia. They don't understand spoken words anymore. It just sounds like if somebody speaks Greek to me. Slurred speech, that's dysarthria. That slurred speech, that may be the last time you hear me use that word. I'm going to say slurred speech. Sudden and severe headache, possibly confusion, dizziness, weakness, combativeness sometimes, restlessness sometimes. Tongue deviation, you tell them, stick your tongue out at me all the way, and you show them, you go, stick your tongue out like that. And they go, that is an important sign to note if they're having other possible signs and symptoms of a stroke. And then coma, you say, stick your tongue out at me, but they're totally unconscious, unresponsive, and staying that way, and they don't do anything. Cincinnati stroke scale, there are a couple of different stroke scales. I'm going to talk more about the Cincinnati. It's the easiest. It was the first. If your patient is having stroke-like symptoms, they're having slurred speech, they have altered mental status, they've had a syncopal episode, we need to go ahead and work through the Cincinnati stroke scale. We need to tell them, look right here at my nose and smile real big for me. And then you show them, smile real big for me. And they think they smile real big for you. One side of the mouth goes up and the other one stays the same or goes down. That's facial droop. Or it's just obvious. You get there and one side of their face is down like this. That is facial droop. Arm drift. What do? We have them hold both of their arms out, close their eyes. Closing their arms is important. If you have to help them hold both of their arms straight out, 90 degrees from their body, straight out, and you tell them to hold their hands there. Raise your hands straight out for me, close your eyes, and hold your hands there. If they open their eyes, they may compensate and keep that arm up. If they close their eyes, if you have a positive Cincinnati stroke scale, that one arm may start drifting down. They don't see that. They don't know that it's happened. They think they're holding their arms up. Or you have to help them hold them up, and it just goes down real quickly if they're profoundly affected. So that would be normal, stays out straight, both arms stay up, and it doesn't drift down. Abnormal speech, we're going to have them, there are different things you can say. Cincinnati stroke scale, the original was The Sun Shines Bright in Cincinnati. Not everybody is familiar with that, and sometimes you have a little bit of trouble communicating that to them. Most of us have heard the phrase, you can't teach an old dog new tricks. So have them repeat, you can't teach an old dog new tricks. Normal is they use the correct words in the correct order, and their words don't slur together. Abnormal, they get the words out of order, they use the wrong words, they can't speak at all, or their words slur together. Think about a drunk who's talking like this, that they have had a doctor drink, and it is all slurred because the muscles controlled by the brain to formulate speech are impacted, and that interferes with their ability to speak. Any one of the three is abnormal or could be called positive Cincinnati stroke scale. The probability of a stroke based on research is 72% if they have any one of those three. If they have all three, I don't know the statistic on that, but apparently it would be more than 72. What do we do then? We treat our patient, but we also contact our receiving hospital, and if there is a stroke specialty hospital within a reasonable distance to transport, meaning it takes us 5 or 6 more minutes to get there, or we contact medical control and they tell us to bypass our hospital and go to the stroke center your patient's going to do better there. That may not be exactly how they say it, but we need to call a stroke alert. We need to notify somebody we're coming so that they're ready to deal with this when our patient gets there. And then we're going to treat ABCs, airway, breathing, circulation. That's what all this is about. Up to 3 hours. If this is an ischemic stroke and they can use the antithrombolytics, the clot buster medications. That's what this RTPA is that's mentioned down there. This is from the this is from the Advanced Cardiac Life Support book. I just threw it here just because I always need to remember the 3 hours. And here you see more stroke scales, National Institute of Health Stroke Scale, Canadian Neurologic Scale. There's an LA regional, Los Angeles regional EMS stroke scale. Depends on where you work as to which one you use. Just learn to use what you have and understand what indicates that you have a you may have a patient with a stroke who needs to be transported to a stroke center, and you need to start treating them for their signs and symptoms of a stroke. Okay, I have another slide. Okay, what do we need? We need to rapidly recognize there's an issue, and then we need to apply the appropriate stroke scale. We need to be treating life threats as soon as we find them, and then move to this to evaluate them quickly, not get down and do a full sample history, OPQRST. If we recognize that we see stroke-like symptoms, we need to, boom, get on one of these stroke scales, identify whether we think there's a stroke or not, level of consciousness, arm drift, unequal pupils, inability to track your finger when you have them just move their eyes, things like that. Experience will teach you further things to use. These are the big things I want you to get: facial droop, arm drift, and speech time. Why is that important? It's that fast mnemonic. It's not just because we have an acronym. We need to establish the last time this patient was known to be normal, and how does their present status differ from normal. So I'm going to give you a quick scenario, two of them. Or one. Okay, grandma, let's say your friend's grandma lives 10 minutes from your friend's mom, and your friend's mom goes by and sees grandma every day right after work and makes sure that grandma takes her medicine, eats her dinner, all that stuff. And then grandma likes to watch TV for a couple of hours. And then right before grandma's bedtime at 9 p.m., her daughter, your friend's mom, always calls her and checks on her. And grandma, I'm doing fine. I'm just going to finish watching my program, honey. And then I'm going to go on to bed and have my cup of warm milk. And always the next morning on the way to work, your friend's mom stops by to check on grandma, make sure she has breakfast, and make sure that grandma takes her morning meds. Talked to grandma last night. Grandma was fine. Goes by this morning, finds grandma seated in her recliner. She has facial droop, slurred speech, and one side of her body is weak. Do we know when all this started? We don't know when this started. When was the last time grandma was known to be normal? 9 o'clock last night. How does that affect our treatment? Okay, we need to do a GCS on every one of these patients. We're going to do GCS later. We need to establish last time grandma was known to be normal, because those antithrombolytics, or those, not antithrombolytic, those antithrombolytics, those thrombolytic drugs cannot be used after the first 3 hours from the onset of signs and symptoms. So, and we may be the only one to ever establish that. Maybe our patient's conscious alert, they're oriented and talking to us, but they're starting to have signs and symptoms of a stroke. When did this start? Oh, that sounds like time in our OPQRST. Onset, when did it start? Or that sounds like O and T, but how long has it been going on is the T. So either one works. When did it start, or how long has this been going on? I think about 30 minutes. How do you know it was 30 minutes? I was looking at the clock, and this all started about 30 minutes ago. They usually go away by 30 minutes, and when it didn't go away, I got scared and I called you. Boom, we have established time. Now this progresses till they become unconscious, unresponsive, and in that critical 3-hour time period, nobody else could establish the onset but us. So I hate it when I hear people say, I'm just an EMT, or he's just an EMT, she's just an EMT. Bull crap. You're a healthcare professional, and this may save somebody's life. This may determine whether or not they go live in a nursing home for the rest of their life. Bedbound, they can't get up, their face is all drooped, they can't move one side of their body, or whether or not they can get these clot buster medications and return to their normal life, whether or not you established that time of onset. So you're not just an EMT, you're a healthcare professional. Always remember to establish the time of onset. If it is, we don't know, and the last time I talked to her was 9 o'clock last night, it's been 8 hours, it's outside the window. GCS we'll talk about more later. That has to do with level of consciousness, as we've already talked about. Be sure you get a baseline GCS on all your potential stroke patients, and then you're going to trend that like you would vital signs, because it is a vital sign. Okay, support ABCs, manual airway positioning, suction is going to be really important. If they're satting or they're SpO2, remember that's saturated percentage of oxygen on hemoglobin, SpO2. If their SpO2 is 95 or above, we don't need to give them oxygen unless we have protocol that says otherwise or online medical control says otherwise. But if it's not staying at that 94%, we need to supplement. We need to protect paralyzed extremities. Don't let that arm be hanging off your cot when you're going through the house and you're banging it on every door frame and you're knocking their knuckles on everything you come to. You do need to package them so that those extremities are protected. Be sure and talk to them. Let them know what you're doing. Even if they can't talk to you, even if they're unconscious, talk to your unconscious patients. Tell them what you're doing to them. Well, that just seems weird. Well, it's part of patient care, good patient care, so do it. Thrombolytic therapy can be used up to 3 hours. Outside that 3-hour window, there's a high likelihood we're going to kill them, or at least not improve their condition if thrombolytics are given. The earlier the better, by the way. They can mechanically go in and retrieve a clot, and they can do that up to 6 hours. So between that 3 and 6 hour window, they can do that. Past that, it's too risky. The risk to the patient outweighs the potential benefit. In time, they will develop other treatment modalities to assist with some of these things, I think. But for now, that's what we're stuck with. Remember, time is brain. Transport to a designated stroke center if it's feasible to do so. Contact ALS if needed. Okay. Look through those things. If I read them to you right now, it might, I know your brains are about saturated, or at least your butt's tired of sitting and you can't absorb much more. So this is what I always do with these 2 chapters. I spend the bulk of the time on that first one. We're going to bounce on through the rest of this. It's not that this other stuff isn't important, but it's readily apparent from the book. bleeding in the brain, patients with hypertension, like I've already said, that can cause bleeding in the brain. Remember that sudden onset of the worst headache they've ever had. And sometimes that bleeding in the brain itself can cause the hypertension. Sometimes the hypertension causes the bleeding in the brain. That patient condition is going to deteriorate. Sometimes almost immediately, sometimes a little slower. Depends on how big the bleed is, actually. Hypoglycemia, things that might mimic stroke. Postictal state following a seizure, that time after a seizure when the brain hasn't returned to normal functioning, when they're confused, sometimes almost appear drunk. That's the postictal state. That can mimic a seizure. I'm not going to spend time on that. We're going to do that when we do head trauma. Types of seizures: generalized seizure, that tonic-clonic seizure, that convulsive activity when it's that spasmodic contraction of the muscles, sometimes all over the body. That would be generalized. Sometimes it's a focal motor seizure, just the arm jerks up like that and nothing else is happening because one little irritable focus in the brain, one little place in the brain is sending out an electrical stimulus that makes its way down out that spinal nerve, and it's causing the arm to twitch and jerk. Or one side of the face to jerk up and down. That's seizure types. They vary from the kid that in school that they thought just liked to stare out the window at the golf course, which I was prone to do occasionally in elementary school because I'd get bored, and there was a golf course down the south side of our school building, and if I was in a room on that side, I was likely to drift away and watch golf. But there were other kids who maybe were having absent seizures where they just stare off into space, and maybe they don't have a total loss of consciousness. They it's just like their brain stops and they're not there for seconds and then they're back. Varying types. Generalized seizure, that's just multiple areas of the brain, large area of the brain, just firing electrical charges chaotically and electrical impulses, and that's what's causing this generalized jerking and twitching of the muscles that you see. Can go a few minutes, can be longer. Remember to check the blood glucose level if your protocol allows on anybody having a seizure, because hypoglycemia can cause a seizure, or a seizure can cause hypoglycememia. All that muscle jerking, like running a marathon, like sprinting wide open for 10 minutes, and it uses up lots of glucose. So we need to stay on top of that. Complex partial seizure, you have altered mental status, depends on what part of the brain is affected. Sometimes you see just eye blinking, repetitive eye blinking, lip smacking. Particularly see this, small infants don't have that generalized jerking, what we think of as usual seizure activity. Their eyes may look away, like up and to the left or to the right. Anyway, look away from normal disconjugate gaze, and they may just smack their lips. Or their feet may make a bicycling motion while they're smacking their lips. That would be a big time seizure in a little one. Aura, a patient who has a history of seizures, they may start to recognize what it feels like when a seizure is coming on. They start to have visual changes. Maybe they see little floaters in front of their eyes. Maybe they see like halos around, like I'm looking at this computer monitor and there's a rectangular halo around. Everything I look at has an outline of that extends past the object. Different people have different auras. That is can be an indication that a seizure is coming on. Not everybody who has a seizure experiences an aura. Seizures, sudden loss of consciousness, chaotic muscle movement, sometimes apnea. They don't breathe. Sometimes last 1 to 3 minutes. Seizures can be bad enough that they cause brain damage. Depends on whether or not they breathe while they're having a seizure. Oh, we know something to do for that, right? If they're not moving air, if they're not breathing, we can do that for them, right? Drooling, intense salivation, sweating, maybe sometimes hyperventilation, sometimes apnea. Patients, it varies considerably. And then that postictal state when they're gradually returning to full consciousness where they're first unconscious, and then they kind of seem drunk, and then they come around until they're back to normal. That may be where we encounter most of these patients who have had a seizure. So they're going to have reported seizure-like activity if we're saying what someone else described, or witness seizure-like activity would be what we describe. It's going to require an EEG where they do an electrical tracing of the brain to determine if they've had a seizure or not. Status epilepticus. This dang seizure goes on for more than 5 minutes, sometimes up to 30 minutes in status epilepticus. And can be a seizure of, maybe I'm having one, series of seizures that can last up to 30 minutes. So it doesn't have to be one constant one, but if they status epilepticus, they have a series of seizures, and they never fully regain consciousness between. Sometimes it's congenital. It's a cause. There's a genetic cause for it. Sometimes somebody's had a traumatic brain injury. Think of roadside bomb in Iraq, and somebody has a closed head injury from that blast wave, that pressure wave that hit them in the head, and maybe they start having seizures from that. Medications that people take, there's a list in your book. Sometimes it's a brain tumor. Sometimes there's an abscess. There's a pocket of infection in the brain that causes that. Metabolic causes. Hypoglycemia. We know something to do about that. We need to call a paramedic because it needs to be IV if they've had changed the level of consciousness and they're not conscious, they can't follow our commands. Changes in blood chemistry can cause seizures. Poisons, yes. Drug overdoses, yes. Sudden withdrawal from heavy alcohol or sedative drug use that can cause seizures. Sometimes too much of a prescribed medication. Patients can become cyanotic, usually just around the lips. If they're not breathing normally, breathe for them. If they're diabetic and they're taking insulin, it may be that they had their insulin or an oral anti-hyperglycemic agent that causes their blood glucose level to drop. We get a BGL on them. We have an idea of what we're dealing with. Call a paramedic unit to come pop an IV in them and give them some IV dextrose, and that will make a major difference in their world. All right. Look through those things. That gives you an idea of what postictal phase looks like. Patients who've had seizures need evaluation. They need full-blown evaluation by at minimum an ER doc, possibly internal medicine doc or a neurologist. Supplemental oxygen while they're having the seizure. If you can get a non-rebreather mask on them, that's very helpful. Keep them from harming themselves. Move furniture away, that kind of stuff. If somebody's crammed a billfold in their mouth so they don't swallow their tongue, you'll hear that. And the people who do that often don't say swallow. They say, I put my billfold in there so he wouldn't swallow his tongue. Okay, thank you. Here's your wallet back. And suction their airway. Keep it clean. Keep it open and patent with an OPA or an NPA. I mean, you may not get that OPA in there. You may just be sliding an NPA in, and you might be bagging them or putting non-rebreather on them. If you think there's any chance of head or neck trauma, spinal immobilization. Okay. Syncopal episode, that's sudden loss of consciousness. We've talked about that before. Distinguishing between feigning, which is syncope, or a seizure. Typically, a person has a syncopal episode while standing, and they fall, and you have to assess them for trauma from the fall, and then a seizure in any position. Syncopal episode when they regain consciousness, they have no postictal phase. AIOU tips. These are things that can cause altered mental status or altered level of consciousness. This is in your book. This is more detailed than what your book has, but alcohol, epilepsy, that would be seizures. Insulin, that would be that hypoglycemia, right? Overdose or oxygen deficiency, uremia, that would be a metabolic cause. Trauma, either too high a temperature, too low a temperature. Hyperthermia or hypothermia can cause seizures, possibly a tumor. A lot of these we can't assess and determine pre-hospitally. Infection could either be that they have meningitis or that they have a brain abscess. Poisoning, that and then shock stroke or brain tumor. Migraines, high flow oxygen, dim the lights in the ambulance, keep things quiet, transport them. Most headaches are harmless unless you're the one having the headache or your significant other is. Then they can be quite painful to you too. My wife doesn't have headaches, so I can say stuff like that. Need to ascertain whether it was sudden onset or gradual onset, altered mental status with it or not. Hypoglycemia, blood glucose level below 80. That can mimic signs of a stroke or a seizure or just unconscious, unresponsive. I've seen people with a BGL of 20 who could still talk to me. I've seen people with a BGL of 76 who were unconscious, unresponsive, and that was their only problem. Just depends on what their body has gotten used to, I guess. Okay, delirium, that's a symptom. That's these things: confusion, disorganized thought, inattention, memory loss. You're suffering from all of these now because we only have 2 minutes left for me to finish what I'm going to talk about. Good news is we're almost there. Delirium, temporary state, can be caused from infection, changes in medication. You see it most often there, changes in medication or hypoxia reversed easily with treatment. Protect yourself, scene safety. This other stuff hasn't changed. Again, establish that last time that patient appeared to be normal. That is extremely important. And then we're just doing that rapid exam, looking for life threats, working through things just as we've been doing, which we will continue to do in lab. Ventilate them 10 to 12 times a minute. You know how to do that. Investigate the chief complaint. Sometimes that's difficult with somebody with altered mental status. We look for things like a medical alert bracelet, medical alert tag, what medications they're taking. Do that full head to toe physical exam. 2 reasons. You may find something in that takes you from this is purely a medical situation to this is a trauma situation. That's the biggie. Or they had a syncopal episode, but they crashed into the table on the way down and they have a brain bleed because of it. Maybe they're on a new blood pressure medicine. They stood up, got dizzy, they fell and whacked their head on the table on the way down. Reassessment, we're going to monitor those ABCs, serial vital signs, and we need to get stay on top of that Glasgow coma scale along the way. Again, I'm not going to make you memorize that yet. You have too much other stuff to worry about. Interventions, airway adjuncts, positive pressure ventilation, any other indicated treatments, suction, and monitor their changes from the baseline and report those to the receiving hospital. Call a stroke alert if indicated. Notify the receiving facility of your ETA. We're done. Man, I owe you 1 minute. We made it. Okay, I will get these PowerPoints, which differ a little bit from the canned one. I'll get these up to Blackboard for you, and I will get this converted to MP4 and get it uploaded to my YouTube channel for you. Any questions before we go? Tutoring starts at 12:30. I'll kick the session off, and then I will excuse myself. So I'm going to go eat a sandwich now so I don't get hypoglycemic. Anything else? Everybody good?
Will you go over the schedule, what you explained at the beginning of class?
Sure.
I just want to write it down, make sure I got it all right.
Yeah. In fact, I can do an announcement on that, but I'll go over it. Okay. Monday, we're going to have an exam over Chapter 16, Chapter 17, and then we'll cover Chapters 18 and 19. Tuesday, we'll have lab. That'll be the last day of June. On July 1st, we'll have an exam over Chapters 18 and 19. I'll lecture Chapter 20, which is the diabetes chapter, the immunological emergency. No, that's not diabetes. Immunological emergencies. That'll go faster. That is that anaphylaxis chapter. That'll go even faster. And then Nicole will have review time with you, discussion time with you after I finish 20. And we don't get extra days off for the 4th of July, but we will, when we come back on July 6th, there will be an exam over Chapter 20, and then I'll cover Chapters 21 and 22, and then lab, and then we're back on schedule. That good?
Okay.
All right. I'll get an announcement up on this. I have to run to Borger later this afternoon, so I have to take care of the immediate things and kick off tutoring, and then I'll get cracking on an announcement for those calendar changes. Everybody good? Anything else? Thanks. I know it's a long, hard class. There's a lot of information. But you guys are doing great. Whatever you're doing, keep it up. Unless you're cheating. If you're cheating, then I don't think anybody is. But if you're cheating, then find a way not to. All right. All right, cool. You guys have a good one. Those of you who come back for tutoring, I'll be there to kick it off, and then I'll disappear. And otherwise, we're done.
All right, buddy. Thanks.
You bet. Have a good one.